This is one of our sub-county hospitals. We will quickly introduce ourselves, and then we have a round of our outpatient area, so that we link idea. There is an interest in immunization. We try and link immunization, family planning, and nutrition services. And a bit of maternity area, a bit of theater area, and then we'll come and have a sitting and see what is it that you've seen, what is it that we can improve, and what is it that we also have from our side.
My name is Dr. Isaac Kimani, the project manager, Transforming Health Systems. It's a project that is run at the Ministry of Health headquarters in Nairobi. I'm the project manager, and that project has supported, this is one of the facilities that has supported all the 47 counties in Kenya. And this is one of the facilities that has been supported, and the THS has both the global financing facility and also World Bank together funding this. So whatever you see about THS or Transforming Health System is funded by both the World Bank and the global financing facilities.
We organise for delegations of parliamentarians such as Maggie and Judith to come out and meet you all and see the fantastic work that you do, and meet some of your beneficiaries. And then, as I say, we take this message back home with an increased passion to want to do more and get you more money and give you more resources to be able to continue to do the fantastic work that you do, and to come and meet the people who are working on the ground and to hear their experiences and hear their stories. And then we take those stories and that message back to the UK and to parliamentarians and others to encourage them to raise more funds for global health through facilities like Gavi, the Global Fund, the GFF.
So we have a lot of cases of children with malnutrition, children who are underweight and stunting. So we see them here and we are able to provide the services for them, whatever they need. We have our nurses here, Otiso and Diana, and she's our records officer, she's Judy. So maybe Otiso can tell us briefly about this room.
This is our antenatal room where we see mothers who are expectant. First, as they come, of course, we welcome them so that they feel comfortable. As they come in, we have the first timers who are starting their clinics, and we have the continuation clinics. So as they come in, we give them health talks on, of course, on danger signs. Before we start anything, we tell them about good health and the diet they need to eat. And then after that, we have now the normal routines where we do the antenatal profile. Of course, in profile, we have so many things inclusive. We do the urinalysis to check if there's any infection, and anything like glucose, protein, so that we can be able to rule out any hypertensive cases which have not been noted. And then we do blood group, so that we know the mother's blood group. Of course, we know we have rhesus negative, where we take care of the mothers. As from 28 weeks, we know they need the anti-D, and immediately after birth, within the 72 hours. Then we do VDRL, that is for syphilis. But we have a dual kit for PMTCT, which does both. Which, when we take the HIV test, it shows both. We use the dual for the HIV testing and for the VDRL, that is for the syphilis. Then we do the random blood sugar for every woman who is coming for checkup. Of course, we do it from the start and at the end. Then we do hemoglobin level. We check as she starts what is her level of blood, so that we can be able to know if it's low, we give imatinib. Of course, we have the Hivas, which we give is a combination of iron and folic acid. And then if it's normal, we advise on the foods to eat at home, so that we monitor it to the end. But at some point towards the 9 months, we do a repeat check of every woman before they go to deliver, so that we know the blood group is enough, so that if it's low, what is it that can be done? If it's a transfusion, but usually we correct it before term. Then we do other things, of course, mentally for the baseline, that's what we do. Then as they come in, of course, we take blood pressure, we take their heights, we take their weights, and we give them tetanus injection. we do holistic care inside here. We do HIV testing inside here. If there's a client who is positive, we have the next room. That's what I say, holistic care. We don't leave the mothers going round because of that stigma and the privacy of the patient, the client, I mean. So once they are positive, but before then we do the pre-test counseling, because others are first timers, others are continuation, but they have never tested the HIV, like if maybe she had been going to a clinic and she missed, because there are those who come when almost to deliver, depending on where she has come from, like those who are coming from far, like refugees. So as we do the pre-test, we give consent. She gives consent. We don't ambush. We do the test. If it turns negative, we'll congratulate the mother. And then we tell them at least it's good to bring the partner, because her test is her own. It's not for the husband. So we encourage husbands to come. But before we get the husband, we congratulate her. We give her what is necessary. But if it turns positive, then we give post-test counseling first inside here, so that we make the mother feel like as she came, before we send her to another process where she can now be talked about ARV starting, to start ARV as early as possible. Then when she is very comfortable, for us to take her to another room, because I cannot take a mother who is crying, that I must make her comfortable like she came in, so that she be the way she came in. Then now I'll call my colleague who is in the other room for now the other continuation of comprehensive care clinic on ARP for pregnant mothers and also the unborn. Now inside here, the IFAS we give for every woman who is pregnant as early as they know they have conceived. Yeah, daily up to term. Even after delivery, we tell them also to take, because they lose blood for some time.
Is this the iron
Yes,
folic?
iron and
Yes.
folic.
Yeah, okay.
Iron and folic.
This is what we have.
Okay.
Yeah. Then we have what we call Linda Mama. It's energy for pregnant women. Our mothers don't pay anything. They are catered for. From time of conception up to delivery and after. For those months after the delivery, they never pay anything. So we do the Linda Mama. We do the scans, obstetric scans, at least 3 eyes, from the first trimester, second, and almost to the third, so that we monitor the baby all through to birth. Now, other than the Linda Mama, we have teenagers. We have teenagers, we have middle, and even 40s also come for the clinic. But we have a raised number of teenagers. Like now, if you look at this place, 10 to 14, of course, we rarely get, but we get 1 or 2, rarely. But between 15 and 19, it's a bit high. Like if I take the 2 months ago, like in June we had 86. For this month, last month we had 76. So we can see it's a bit high.
From the beginning of the year.
Yes. And then holistically or wholesomely, we have so many mothers. We have so many clients who are taken care of now that we are in a locality where we have the population is a bit high, and we give them the good care they need. At least in a day we see between 50 and 60 clients per day, inclusive from the teenage up to the others. In a month we see minimum about 800. Wow. Unless it's a holiday, because us going 2 days in a holiday affects us, because that's around 150 mothers. Our number comes down slightly if we have holidays like December. But if there's no holiday, it's between, like if you see last month we had 930 in that month. Last month but 1. Then July 882. That's what we do. We do TB screening in this room. Of course, the TB screening we ask. We don't test inside here. A mother can come coughing, knowing like it's a normal cough. But as we take the signs and symptoms of TB, so that we can be able to rule out TB before before late. Then we do the other things like issuing of nets, yeah, for every mother who comes in. The nets are free, everything is free for those mothers. Everything, I mean everything, as they come and as they leave until delivery. Essentially, that's what we do inside here. And
how many of the women who come will test positive for HIV? What percentage?
Yeah, our number is a bit reduced. It's reduced. For the positive cases, we have been able to, we do screening, improved screening and testing of HIV as early as we can, so that if there is a case, we deal with it as the baby, before the baby is born, so that we reduce the number of prevention of mother-to-child transmission of HIV, which is really reduced. Like, if you look at HIV positive,
yeah.
These are the cases we get.
Yes.
It's on a reduced number.
Yeah.
So at least we are able to deliver normal HIV negative babies from positive mothers. Because we start early and we encourage mothers. Yes, they can come with resistance when they test positive. It's normal to feel what they feel. But we are there for them. We talk to them until they agree to start the medication. If she's not able to start, she's not willing to start today, we don't leave the mother to go. There are so many rooms.
If you're having like 900 a month, 900 a month, and you've got 4 positive.
4 positive, yeah. On that month we had 882. In that month there was 4 positive.
Yes.
In the other month 930 and there was 2 positive.
Yes.
So yes.
And all of them are put on care as early as possible, as we encourage also the husbands to come. And then on the process of testing, of course, there are those mothers who test negative, but they feel they are at risk of getting infected. We have the pre-exposure, the PrEP, the pre-exposure prophylaxis. We talk to them. They can say, of course, my husband is not here, but I feel I'm at risk. We give them the pre-exposure drugs, that's PrEP drugs, so that they can start. But we encourage their husbands to come. And what we do here for the husbands to come, we usually go outside as we give the health talk. We ask who has come with the husband. You know, men are impatient in a way. In nature, I don't know, I'm not accusing him. They are a bit impatient. So we take those mothers so that we can also encourage others to bring their husbands. We give them priority, even if they came last.
Right, okay.
We give them number 1 so that they can tell their husbands, if you go with me, so that we can get the husband to be tested. If you go with me, then I'll be given chance. So as they come inside. Now when the man comes inside, he doesn't have that space of refusing not to be tested. There's a way we talk to them and encourage them. So that, of course, if you see the spousal couple testing, at least we improve. They are here. Yeah. Of course, the number is not high, but we are trying. These booklets are health talk for its own. So we encourage mothers to read. Like, we tell them to, I ask the mother, there are 2 letters inside here. I don't know whether you know it. There are 2 letters inside here, but the mothers are not aware. They say that pregnancy, how they are supposed to take care of the pregnancy and the baby who is unborn. And then we have the last one, dear to the young adult. The young adult is the baby who has now been born, to be given this book to read.
So we do the screening here for malnutrition and also the warming. We have cases of malnutrition around this area, attributed to poverty. So many poor people around, and most of the children are taken to the daycare. So the daycare is so congested that even the care they are given is very low. So this attributes to malnutrition and also stunting.
And then now their book is filled, the child welfare clinic. That is filled up here. Then the nurse is able to note what service they are coming from, which month, which schedule. This is our Kenyan schedule. So we have the schedule for routine immunization that starts from birth, 6 weeks, 10, 14, 9 months, 18, and up to 5 years, under 5 years. So that's our schedule in Kenya. So once that is done, then now the nurse can do the immunization. So she will just maybe give this child Abari Baba. So she has, the father brought the child.
No, dissociation, vital.
What about the yellow fever?
Yellow fever. It's not among the shade. This is not a yellow fever endemic here. Yeah, that one is different.
Another question. What about the
rotavirus? The child was given rotavirus at 6 weeks, 10 weeks, and 14 weeks. So that we usually give only 3 doses.
Yellow fever, yes, in some areas in Kenya, it's given at 9 months, but we're not a yellow fever endemic zone. So that's why in Kajiado
It's in the very north of Kenya, it was.
in the Rift Valley.
Northern Rift?
Yeah, northern.
You're being watched, aren't you?
Oh, good baby.
Oh, no, you.
It's not the best reaction to that scene.
So we used to burn our, waste there, and this other compost area we could burn the paper, the non-infectious waste. So it was really hazardous for the environment and for the people. Yeah, even for the people who, the workers who do the waste incineration, it was really hazardous for them. Yeah. So that is when now that in 2021 we got the incinerator. It was also funded by CHS. So it's a modern incinerator. So we are able to incinerate for all the private hospitals in the area. We are able to incinerate for all the public hospitals and all medical waste. Yeah, so we do that at a fee.
And so you can make money.
Yeah, so it's
Income generator.
Yeah.
It's an income.
What's THS?
Transforming healthcare.
Okay.
We don't have a licensing, that is the environmental licensing. So they've taken samples and they've licensed us, they've licensed the incinerator, so it's safe for the environment. Also the distance is like 50 feet from the neighboring, from the houses. Yeah. So it's safe for the people who live here. And the air that is producing is also safe, but it could be safer without spreading. I see. All the waste is brought here and also considered for other people, like other costs. Yeah. So one here is our guy, he has the protective gear. So he does that one. So this room, we store the waste in our room. So when then he's able to segregate it. So there's a way that you have to balance the plastics versus the metallic things while putting them in. So he's able to do that and then incinerate. Then after delivery, there's another room after delivery where they go to. So how many do you have today?
We have 6.
And how long will they stay in?
So here they stay for about 2 hours for observation after delivery. Then they go to the other postnatal room where they stay for 3 days. Then the cesarean section ones, they stay for 4 days. So on average, we are seeing about 300 women here per month delivering. So about 10 times per day here.
Keeps you busy.
We don't have a lot of home deliveries, so that we have that problem in Kajiado County of home deliveries. But here, this is free. Maternity is free. So there's a Kenyan system, there's a government system that is called Linda Mama. It was introduced by the Ministry of Health a while ago. So women deliver for free. From pregnancy to delivery is so free. So they come. But you have the problem of home deliveries in Kajiado County, the rest of the Kajiado County, where we have long distances that we travel to the facility. And also the lack of facilities, like over 20 to 50 kilometers per area, so they're not able to access. So we have a lot of home deliveries in those areas. Then after delivery, there's another room after delivery where they go to. So how many do you have today?
We have 6.
And how long will they stay in?
So here they stay for about 2 hours for observation after delivery. Then they go to the other postnatal room where they stay for 3 days. Then the cesarean section ones, they stay for 4 days. So on average, we are seeing about 300 women here per month delivering. So about 10 times per day here.
Keeps you busy.
So Rachel and her team.
Will you tell or will they come back?
They do come. We don't have a lot of home deliveries, so that we have that problem in Kajiado County of home deliveries. But here, this is free. Maternity is free. So there's a Kenyan system, there's a government system that is called Linda Mama. It was introduced by the Ministry of Health a while ago. So women deliver for free. From pregnancy to delivery is so free. So they come. But you have the problem of home deliveries in Kajiado County, the rest of the Kajiado County, where we have long distances that we travel to the facility, and also the lack of facilities, like over 20 to 50 kilometers per area, so they're not able to access. So we have a lot of home deliveries in those areas. So the other room is the postnatal room, where they rest like for 2 hours after delivery. After then they are done, the vitals are done and they're checked that they are okay, then they move now to the postnatal where we shall go shortly. So there's the kit that they are wearing to help support the baby on the chest of the mother, and our nutritionist will tell us more.
Okay, so currently we have 3 mothers who have babies who are underweight. The first one is 2.1 kgs, this one is 2.4, the other one is 2.3 kgs. So we are doing the kangaroo mother care. So kangaroo mother care basically is the prolonged continuous skin-to-skin contact between the baby and the mother. The baby has only the heart and the socks and the diaper. So the mother provides warmth to the baby. And this KMC mother, kangaroo care mother, has so many benefits. One of them being the mother provides warmth to the baby. It also helps the baby to gain weight. Also there is reduced infections, yeah, and also it promotes exclusive breastfeeding. So the baby, when the baby is here, the baby can easily breastfeed. Also the hospital stay is reduced because of the reduced infection, and also the baby gains very fast, so the hospital stay is also reduced. Issue of referrals, because currently we don't use the incubator because we already have these bags to keep our baby warm, so we don't use those machines to give the warmth to the mothers here. So the issue of referrals to other facilities are reduced. We manage the underweight babies here. We discharge them when they are very okay, and also we do follow up.
Congratulations.
My name is Dr. Marian Mukira. I'm the medical superintendent at Ongata Sub-County Hospital, and also the Sub-County Medical Officer of Health for Kajiado North. In Ongata Sub-County Hospital, we have a theatre. It was constructed in 2015. However, it was not completed. It was done by the county government. So renovations were supported by, in line with the coverage for universal coverage. So the Transforming Health Systems project was the one that renovated that theatre in 2018-2019. And the theatre was opened in 2020. It has 2 theatres, and we used to refer maternity patients who require cesarean sections and any other theatre cases. We used to be referred to Nairobi, or about 60 kilometers away, to Kajiado County Referral Hospital. So since then, we do not refer patients. They are able to get access to quick care. We have about 300 deliveries in a month, and out of those we do 40 to 50 cesarean sections every month. So all those women, we are able to give them quality health care in a timely manner. Yes, we have a few challenges. One of the theatres is incomplete, so we only have one that is complete. So the other one lacks an anesthetic machine and equipping. So that's still pending, so it's not in use. So if that theatre were to be completed, it would really increase the number of cases we are able to see per day, and also not limit the number of cases that are done like in a timely manner. The theatre, we also do some gynecological cases and surgeries, and this has also helped towards giving care to the people of Kajiado North, bringing them specialist care closer to them, and we are very grateful to the project, the THS project, and also to the county governor of Kajiado.
What
what we have seen about nutrition and all that, the impact of, and of course what the guy told us about increasing number of extra assistant TB, whether nutrition have anything to do and whether there is any attempt to address some of those issues.
The county is doing a lot in terms of prevention. So first at the community level, at level 1, we have like in this area we have trained 168 community health volunteers. They are now being called community health promoters. So those ones, they have been trained on various health topics, and they are able to go around and in the community do home visits and visit community members and train and educate the community on various issues about health, prevention, and all that. Then we have also the CHAS, the community health assistants. Those are like government employed workers who are also working with those community health volunteers, making sure that every day, every week, we are reporting, we are doing some activities at the community level. We also do outreaches at the community to make sure that we are reaching out to the areas that are not accessible. So then at the level 1, at the dispensaries, the level 2 at the health centers, and also now at the hospitals. The prevention is all the areas we went through, like the maternal and child care areas, all those are prevention areas. We do the screening at the triage area where we ask about a few questions for TB. So using that, we're able to screen and get the ones who are eligible for testing. At tested, we have the free testing for TB, we have a gene expert, we have the sputums for the AFPs, also free. And then, if positive, we also have the treatment for free. But then, generally, the government is also doing a lot of prevention programs. Like tomorrow, we're starting a polio campaign that is targeting 4 counties because we had a polio outbreak in Garissa. We had 3 children in Garissa. So, because of that, we are going to do 3 rounds of polio vaccination campaign where we are going to visit people door to door. Like we'll go to every person's door. So that way, during that time, we are able to also, look for other things. We're able to look for other cases of polio surveillance and any other surveillance that is required. We're able to ask about just health matters at the community level because we are going to be visiting the homes. So there's a lot of work that is going on for prevention.
If you see from outpatient area, the number of people who are now visiting the facility for treatment, these numbers can reduce if only certain prevention measures can be done. By now there's a lot of health promotion telling now people by just washing your hands after visiting the toilet, you are able to prevent a number of these diseases. There is also what the public health would call open identification, free. Yeah, just ensuring that every village has toilets and all that. And then a special focus even as a county government has been given to prevention. We have a whole law called the Community Health Services Act, some of 2011, that of course talks about the whole line of public health, the whole line of community health strategy, focal people, community health assistant, community health promoters, just from the village level all the way to the county level. So I think a lot of focus has been given to prevention because it is no longer tenable to allow people to come to hospital, so that we try and prevent diseases at the community level, so that when you have to come to the hospital, you must come to the hospital to seek for treatment, because that way it is actually even cheap. Because I was telling Dr. here, if you see the laws of this country dictates that under 5, that is the children under the age of 5, access services in our hospital free of charge. But when you critically analyze the amounts of drugs that cohort of people spend, it amounts to a lot of money. Yeah. So I think that is one of the reasons why we are shifting now the focus from curative to prevention. And Dr. has mentioned the polio campaign that is coming up. I think we have a target of about 177 children to be covered across the county. We have just finished the oral cholera vaccine in some part of Kajiado East, those are the Kitangelas and the Lights, where we were able to vaccinate over 300,000 people. All of those efforts, of course, those are the support we have received from WHO, UNICEF. Those are some of the efforts related to the question about prevention and promoting health.
One other issue that I know is quite innovative here is the issue of health insurance.
Yes.
Would you mind?
Yes, but even before I come to the whole issue about universal health coverage, or what you are calling health insurance, there is a cohort of people, like Collins is mentioning, while they talk about under 5, we in this country, because of our unique nature, have children of up to over the age of 10 years, but they are minorities. And nobody is concerned with this cohort of people. Because the support we receive from UNICEF and other development partners only talks about under 5. But then the question we ask ourselves, what about this cohort of people, who are over the age of 5, but they still suffer, malnutrition? The other thing that is making, as much as we received something from UNICEF on moderate acute malnutrition and severe for under 5, still there's no much improvement. You know why? Because assuming child A is given the supplements, when they reach home, because they are sweet, they share among the 4 of them. Yeah? So whatever this child is supposed to receive, they now receive the 4 or 5 of them. The mama, because maybe they see nothing at home for them to feed. They depend on, you call them what? Folic what? Those kinds of nutritional supplements. It now becomes a meal for the house. I mean, these are truthful, discussion that happens at the community level. Now, coming back to universal health coverage or health insurance. Of course, through the support of Excellency Governor for this county, Governor Lilengu, I started by saying this is Kajiado County. Governor Lilengu came up with an initiative to say, with one goat, which is averagely 6,000, you can get a health insurance. And because of those initiatives, and those people at the urban setup, like where we are now, who do a bit of planting of maize, a bit of planting of beans, with one sack of mahindi or maize or beans, you can equally get a health insurance. And because of those efforts, right now, we have 24,000 households under the program of universal health coverage. So that is where we are. The Ministry of Health, I know that Karin, you know that program. The Ministry of Health came up with a program where they want to scale up the number of indigents per county. And we were allocated another 12,000 households, which we have submitted to Ministry of Health, of course the Department of National Insurance Fund. So when you add 24 and 36, you will get 36,000 household people insured across this county. The county government every year allocate 10 million shilling as a sponsorship scheme for the elderly.
The crops fell time and time again, and with healthcare facilities quite distant. And we were saying the kids were fantastic. They were very well with climate change, probably more so than the adults really. But they were saying that we can be given grains to cook, but if we don't have the water, we can't cook grains. So that's got that huge knock-on effect that he was on. The whole population has been malnourished. And then because of the drought, they're moving from one area to another to try and find the water. So it means that they're even more nomadic than all to get the healthcare facilities that they really need. So hopefully now the rains come, there's a bit more stability so you can do something for them with them.
Just seeing the amazing work that you do in the kind of space that you do really makes me kind of want to go back home and write to the government and say, what more can we do to help out in Kajiado County? And what more can we be doing bilaterally to help out here? And that's just kind of solely down to the fantastic staff that work here and the fantastic results that you churn out. So thank you very much for hosting us. It's been really fantastic.
Yeah, we really enjoyed
Thank
it.
you.
Thank you. On behalf of the representative from Ministry of Health, the national government, on behalf of the development partner led by our Mzee there, Alan, and of course our friends here, Odini, and all of us, we want to really appreciate the visiting team. We want to appreciate for the support. We want to appreciate for you finding time to visit this hospital, or rather our county government, and see the impact, or rather the high impact the World Bank together with the THS or Transforming Health System has created to certain key indicators of mother and child, all the way to theater issues, and the increased number of patients as a result of now confidence about the hospital. Of course, even increase workforce, because whenever there was no maternity, theater, and once you build a theater, automatically the county government employs theater nurses and the medical officers like her. And therefore, in a way, you have also created employment opportunity for the program, funding certain element of the hospital. And therefore, we want to appreciate. We have taken you around. You have seen maybe the areas we are not doing well. We will encourage positive feedback, or rather positive criticism, so that we have room for improvement maybe next time whenever there is anything that you are not going well. Two, we have also expressed our concern on the need. You remember, I have passionately talked about the radiology unit in relation to mother and child and maternity. Of course, the whole issue about infrastructure development, about the outpatient, how to segregate the underpart for children and the adult. And therefore, whenever you find time or whenever you find resources, we will request you that we will be happy to have a further partnership with you going to the future on the two areas. Otherwise, thank you very much. Asante sana. When you go back to London or the UK, please take the greetings of Kajiado County. Thank you very much.
Thank you.